So this patient has quite a Bell's phenomenon, as you can see. The eye is literally pointing upward toward the forehead. So, I mean, I can center it. You're going to feel a little pressure with a cotton tip applicator here. And I'm going to mark the steep axis of this eye, which is about 85 degrees, like so. Now, this patient has keratoconus, and that's a congenital nuclear cataract that has obviously progressed, and she's now 60 years old. So we've got a very dense nucleus there. So I'm going to begin by making a side port entry right here, and a little bit enlargement as I come out. And then a temporal clear corneal 2.4. And this is why you want to use metal, because you can literally rotate the eye downward with your index finger and a metal blade. Diamond, no, wouldn't be able to do that. Lidocaine. You're going to feel a little sting for a few seconds. So intraocular lidocaine. And now we're going to put in some air and then trypan. Now, a keratoconic, highly myopic eye is, you can expect to have low ocular rigidity. Those of you watching in 3D can appreciate that even through the air bubble, the chamber looks and is shallow. The iris is up against the cornea. So let's go injecting across the eye and expel the air bubble. Now we have a nice deep chamber. Spatula. And while sometimes that Bell's phenomenon will wear off as the case goes on, so far in this case it really hasn't. Wet the cornea. You see we have some ink there on the cornea, but I don't think that's going to get in our way. So I'm going to open the central capsule. And you can see the value of the trypan here. I'm going to do a capsulorhexis that my expectation is to get one a little bit bigger than that nucleus. Now the question is, does this patient have also a congenital posterior polar cataract? And the answer is, we don't know. The other eye has a nuclear cataract, and I can see that there is not a posterior polar cataract. So my plan here is to do hydrodelineation. Wet the cornea, please. So I'm going to put the cannula down in here next to this nucleus and then outline it like that. And then I'm going to do some viscodissection around it. And then we'll get the nucleus out before we find out about the posterior capsule. Okay, so I'm going to begin with a spatula here. And I'm going to use that to just kind of lift up the nucleus. Quadrant removal.
Quadrant removal.
There's the central core of the nucleus. And now what amounts to epinucleus. So now, it looks to me like that posterior capsule is probably just fine. So now we'll go to hydrodissection, cortical cleaving hydrodissection. So there's our flat cannula. I'm going to put that out under the capsule and do a little cleaving hydrodissection there. And maybe we can get in here. We have a side port blade. And do a little bit of that in the subincisional area as well. Quadrant. So you can see we mobilized that epinucleus pretty well. And as we expected, the posterior capsule is just fine. So provisc into the capsular sac with the cornea. And then we'll insert this. And here we're using actually a T9 toric IOL. Need you to look toward my side. Good. So with the IOL and the capsular sac, we'll rotate it to almost the 85-degree meridian. And then we'll go in and remove OVD only from behind the IOL here. I'm watching that haptic over there. It hasn't released yet, so I may have to release it. Looks like I will. So I'm going to put this around the edge of the optic and then release that haptic. So OVD removal only from behind. Leaving it in front. And then I'll use the spatula to position the IOL. Because if I remove that OVD from the anterior chamber, there's a very good chance it would flatten completely. And that would obviously be undesirable. Okay, so that's pretty close to 85. Look straight into the three lights toward my side. Good, stay just like that. Yeah, that's good. So now we'll remove the OVD from the anterior chamber, and we're going to do that just by irrigating. First, I'll do stromal hydration. Side port stromal hydration. And then we'll get the OVD out of the anterior chamber, especially the angle. And the IOP is a little firm. Now a little soft. That's good. So there we have a congenital nuclear cataract, no posterior polar cataract, and a keratoconic eye. And we're done.